So now it's good? Okay. Okay, thank you. So, of course, I'll follow up with Dr. Ahmed Khulif. He had a much more interesting case than this. This is a rather simple case, and the idea, and this is why I try to combine the case with a few pertinent points, especially for our younger generation viewers or participants, so they might get some of the basic knowledge about these cases. It's not moving. Okay, I'm sorry. These are my disclosures. I do have to show them up. And so these cases, I want to define the pertinent points in the history taking that might alert our suspicion regarding a simple ankle fracture, or what is called a simple ankle fracture. We should know when to use added investigations or diagnostic modalities, and how to approach these fractures systematically and in a stepwise fashion, and perhaps learn a few guidelines as how to assess if we have done a good and adequate reduction or not. Now, this is the case. So he's a 30-year-old male. He's a tourist guide. He's actually the brother of one of our radiologists, a good friend of mine. He's also an indoor national soccer football player. So he plays for the national team. And he had this injury while he was playing football with contact or with an opponent on the indoor pitch. Now, the radiologist, he sent me these x-rays and he told me, Nassif, look, it's a simple fracture. I think he's going to have a conservative cast. مش كده يا ناصف? So where would I send him? Which one of the hospitals would some of your assistants be able to cast him in? And I needed to ask him one question to be sure on these x-rays, is that possible or not? Is this case over the phone? Am I going to treat him conservatively, or am I going to ask for something else? And this was the question I asked. It's not moving again. Okay. I asked him, when he had the injury, did the people around him, his teammates, what was the position of his foot? And they said, no, it looked really bad. They had to correct his foot back to where it should be. And that's when I said, no, this does not look like a simple injury. And so, why is that? Because of the classification. We all know this, we are not going to discuss this. This is a supination external rotation injury. And we know that these are the most common injuries that we're going to see. 70% of your ankle sprains or fractures are going to be the supination external rotation. And we know the classification, I won't go through it. But what I would like to draw your attention to is, although stage 3 is said to be stable, and we can discuss this later as in between us as a panel, but this involves the posterior malleolar fracture. So is it really stable? But what we are concerned with is the unstable, is the type 4, the stage 4, because this differentiates the oblique lateral Weber B's. If it has a medial malleolus, of course it's now a bimalleolar fracture. But if it has a deltoid, then it is also considered unstable. So comes the question, is it going to be treated conservative with these x-rays? And I would like all the participants just to take 10 seconds and decide, are you still going to treat this patient with this simple ankle fracture conservatively? And what would you base your opinion upon? And those who even think that they would treat them operatively, what are the bases? On this plain x-ray and that simple history of the question, is that enough, or would we need additional investigations? So a question just for the esteemed panel, of course, it's much less than their capabilities, but which one of the panel would like to add a certain view or a certain investigation for these? Anyone has any specific recommendation? Dr. Ahmed, Mukhtar, Osama? Okay. Yes. Yes.
For something simple, the mortise and oblique view.
Okay, that's also a very good idea.
View, and I
would love, if the motive you show some syndesmotic instability, I would ask plain X-ray for the contralateral side.
Perfect.
To compare the syndesmotic space.
Okay.
Yeah, that's why I think we should do some form of stress views. I don't know.
Exactly.
Eric stress views or the gravity stress views. I don't know what you like, but
Yes.
I think it's considering such the differentiate between type 2 and 4 of this.
Exactly. So as the participants can see, what the panel is trying to look for is, yes, there's a fracture, but is there an added instability with this fracture? And to do that, you have to look for a stress view or a type of weight-bearing view to decide, is this ankle stable, supination external rotation type 2, then you would treat it conservatively. But if it's a supination external rotation type 4, having a medial plus or minus a syndesmotic injury, then you will have to treat this operatively. It becomes an unstable. So these are the stress views. And as you can see, it's a weight bearing. I could have done the CT, I could have done MRI, I could have done stress views on a fracture, maybe. But I actually had the patient with the fracture standing. And these, as you can see here, the medial space opened up, and we'll show it in comparison. The talus shifted. You can see the tibial plafond with the talar, and the syndesmosis shifted. And these are the comparative views, as you can see, between the non-weight bearing and the weight bearing. So now I know that I have a unstable fracture. I still don't know what is exactly unstable. Is it the syndesmosis? Is it the deltoid? Is it a combination of both? So as
Dr. Naaser,
yes,
I will, if the patient can weight bear and you can do an X-ray, I think there's some sort of stability, because I
yes,
in the motive view it is not that clear that there is some shift or the tear space is obvious.
yes, and that's
But if a patient who can weight bear on his ankle, which is already fractured, that can give me a clue.
I will come back to this in just 2 slides from now, and there is evidence behind that. But that's a very, very good point, Dr. Zahar. So, as we said, we want to detect the stability. Is it a supination external rotation type 2 or is it type 4? Like Dr. Ahmed Khidr said, one of the most commonly used are the weight-bearing views. And these are very easy. You can have the patient on the same wheelchair. He doesn't have to stand, and he can show, and you can take an AP of the ankle in direct AP hanging from the side of any table, and this would convert what you would think would be a stable fracture into an unstable. Other proponents are the proponents of the standing weight-bearing views. Now, like Dr. Zahir said, some authors decided that if you can walk on it, if you can stand on it and bear weight, then it's probably stable. But actually, this was not shown to be true. But like Dr. Shazli said, it's best if you get comparative views. And I'm not saying that you have to get gravity stress comparative views, but definitely standing comparative views, and definitely even if you're not going to have the patient in a fracture condition, you should get comparative weight-bearing views to pick up the subtle, for example, Lisfranc or other types of injuries. So to detect this stability, there have been questions. Some people advocate that in fractures, simple radiography is enough. So not the CT and not the MRI, as probably Dr. Ahmed said, because the CT and an MRI would be more significant in ligamentous only injuries. Others stated, like Dr. Zahir, that it is best if the weight-bearing X-rays, these are not indicative of medial clear space widening. And they said that the talus often centers itself under the mortise, and so it is stable by nature. But actually, this was not true, because long ago, from 2010, it was defined that the weight-bearing X-ray, if the patient can weight bear, is better than the gravity view, and this is because of this simple idea. In the gravity stress view, the ankle is plantar flexed by definition because you're getting it to be along the gravity. In this position, you see this was a gravity stress and this was a weight bearing. So the unstable became stable. But that is the paradox. This is because the posterior tibio-talar ligament, which is the most strongest of the deltoid, is the tightest when the foot is in neutral, so when the patient is standing on it. Meaning, if the patient on weight bearing, if the talus shifts, then you definitely know you have an unstable type 4B, which is a difference. 4A is a partial tear of the deltoid. A 4B is a complete tear of the deltoid involving the PTTL. So in my point of view, and in some other authors, the weight-bearing X-ray, if the patient can bear weight, is a better view to demonstrate the stability and hence your method of fixation for these patients. But again, is this a sure sign of syndesmotic injury? Is the standing X-ray with an opening and a medial opening, is it a sure sign of an instability? And have you, by this X-ray, diagnosed, is it a deltoid injury partial, 4A or 4B? And this is why we need to know the stability of either to know how to progress with the fixation. So now that we have done, for example, the standing or the weight bearing, is this enough? Would you still, Dr. Ahmed, want to do a CT? Dr. Ahmed Khulif? Yes. Would anyone else of the panel want to do any additional information, any additional?
Yeah, and according to what you have said, that the weight bearing
Yes.
is not a good sign of stability. Does not, but it is a good positive, but it is not a negative.
Actually, Dr. Zahir, it's the opposite. The gravity stress is not a good positive, but it's a good negative. The weight bearing is a very good.
Weight bearing,
Yes,
I'm talking about the weight bearing. Weight bearing is a good positive.
it's a very good positive.
Yes, but if it is negative, does not exclude instability.
Yes, but no, if it is negative, then the patient is stable.
Okay.
So that,
Good positive.
yes, and it also excludes that the patient is unstable. Of course, if you want to take it a step forward, you can at that point. If you want to be sure you are going to treat the patient conservative, you can at that point in time do the added expense of the CT to look at the syndesmosis and detect if there's any talar shift. But also papers have said to do that, you need to do a comparative CT of both sides. So actually, and I know Dr. Zahar, you're probably going to kill me, but I also decided I would need to do an arthroscopy. And I'll show you what I meant. I wanted to make sure that what I am seeing on the X-ray is unstable. So I looked at the syndesmosis, made sure that I could open it more than 3 millimeters, which is now the recommendation. And if you notice, these X-rays were in 2016. So this incident, this happened in almost 4 years ago. And I also detected that the syndesmosis is unstable in both the coronal and the sagittal. So this was the addition of the arthroscopy. And I will show you in a few more slides if there was another value. I know that we can debate, is the arthroscopy of value or not? I believe it was in this particular case, even though there are no other injuries, but it decided for me the stability of the syndesmosis and the stability or otherwise of the deltoid, and I'll show you in a while. And this is a very nice article. It's a review article. It came out in 2018, and they decided that MRI 3 Tesla in the plane of the syndesmotic ligaments is the investigation of choice for ankle syndesmotic injury. However, in the presence of associated injuries like fracture, arthroscopic viewing with stress examination during the arthroscopy is the diagnostic benchmark. And this was a radiology paper. So it showed that up to that extent, they are not sure of their own radiology as opposed to a arthroscopy. And of course, that changes the picture. So what about the syndesmotic injury itself? As you can see here, there's a hook test that is being done, and at the same time checking. This is another case. And we also wrote up something about the direction of the instability, because it can be, the syndesmosis can be in any one of these three planes. And to detect this deltoid injury, I personally, while growing up, I was taught swelling, ecchymosis, medial tenderness, or even the Lab-Hansen classification. And this has been proven almost 10 years ago now that they are not adequate predictors of the integrity of the deltoid. You still have to look at the deltoid end on or at view to know if it is completely cut or incompletely cut, because that is going to define the stability in this supination external rotation injury. So now that we have decided that perhaps this is an unstable injury, we are going to go for a fixation. So what is the operative technique? Would you fix your fibula first? And when would you decide to approach the medial side first? Anyone from the panels has any idea? Has any suggestions, I mean?
Dr. Nassif, sorry for the interruption. Just please disable attendee annotation because
Yes.
on the options about the review options, you will have an option to disable
Okay.
the annotation.
Yeah, sure. I noticed, I thought my computer was doing crazy things on me. Okay. Disable, annotate. Okay, more. Okay, yes, I found it, and I'm sorry, I've done it now. Okay, so for sake of time, panelists, would you, in any particular case, approach the medial side first?
Thank you, Dr. Nassif, for this very nice case because in my experience and in all our experience, it's a very common mismanaged injury.
Yes.
I usually start from the lateral side, except if the talus is not reducible in the mortise. If the talus is not reducible, then the deltoid ligament is inverted inside the ankle joint, preventing the talus to be centered. Then I open medially first to clear the medial space for the talus. But if the talus is reduced, then I usually start with the lateral side. I don't
And
know if all other panel agree with
just a small question, Dr. Mukhtar. How would you know that the talus is not being reduced? Would you do that clinically with your hands, intraoperatively?
image entry,
Intensive.
intraoperative with image entry.
So you use your own manual force and try to reduce the talus.
Yes.
Okay. Any other one has any ideas?
I do the same, but if I have the truncal ligament injury with talar turf and shift at the same time, which is a diagnostic sign, radiological sign for the third ligament, before I go for fixation of the fibula, I just preliminary fix the fibula, and before I fix the syndesmosis, I do correction for the third ligament first, to be easy to find it and to fix it. Because if you close the syndesmosis, close the fibula, it will be difficult to retrieve the
Yes.
syndesmosis.
Okay.
But the problem then, Dr. Osama, is that if the syndesmosis is open and the talus is not perfectly centered, you will suture the deltoid in a limb.
Relax. Yes.
I mean, you preliminary suture, you don't tighten the suture, you expose the
Just
deltoid,
take the
you
suture and
retract
then
it,
tighten them at the end.
and you retract the
Yes.
ligament from the medial space, because if you close everything, it will be difficult to retract the ligament from the deltoid.
Yes, this is exactly what I think. I might just add that if the supination external rotation has a very high degree of comminution or is very, very osteoporotic bone, you cannot depend just on the lateral pillar of the fibula, and you have to reduce the talus itself in one direction, and then you build up the fibula depending on the talus back into the mortise. So in this condition, you might think about reducing, not repairing the deltoid. So in this case, I went ahead, I fixed the fibula, I brought it out to length, and I think this, especially for our junior colleagues, is the most important part. Whatever you do, you have to anatomically reduce your fibula, length and rotation. And we will see this in a while. This is the most important step. We can talk all day about syndesmosis and deltoid, but if your fibula is off-ended, if it is not brought out to length, if it is rotated, this will end up in arthritis in a couple of years, not even more. So the anatomical reduction of the fibula is the most important. And to do that, we know that we have to know the rotation by the dime sign. This is easy. Now I want to ask the panel, what about rotation? Do we now have any clue in 2020 how to assess the rotation of the fibula intraoperatively during our operation? Panel?
Okay. There is the acute fracture and the malunited fibula.
Yes.
In the acute fracture, I depend mainly on the anatomy of the fracture.
Yes.
If the spike of the spiral fracture is in its bed, then the rotation is correct.
Perfect.
But in neglected cases, it's very, very difficult to preoperatively determine the rotation.
Yes.
You have to depend on your sense intraoperatively. And I discussed this point a lot with many surgeons.
Yes.
That the problem of rotation cannot be assessed accurately preoperatively or even intraoperatively.
I think it can, in preoperative, and there were studies about CT scan rules in
Yes.
particular rotation in preoperative assessment.
Yes.
The challenge is the intraoperative.
Exactly.
You can do it. You try to guess according to Bob's view intraoperative.
And this is
How the fissura is reduced or not. There is no definitive method, I think, in most cases.
yes.
To assess rotation intraoperative. We see the scans easy.
And this is why, of course, like Dr. Mukhtar said, if you have a fracture, it's easy. You reduce your fracture, you know that it is your rotation is better. But I came across this very, very, very nice paper in injury, and it was actually came out in 2018. And this is a method to assess rotation. We do not have intraoperative CT in Egypt. We do not have even intraoperative weight-bearing CTs, which are now the standard. So if you take this, it's a reliable method. It has been proven. It has been validated. So you take a line across the the lateral talar cortex and the medial talar cortex, and this is the malleolar fossa. Now AB, this line, should always be more than BC, and the number is almost 1.3. Now let us take this clinically and look at the picture. If your fibula, and this is better for malunited, if it looks like a spoon, if the syndesmosis is open, and if you feel that the talus is very close to this is internal rotation. In the external rotation, it looks like a knife. The syndesmosis is too much closed and the talar gutter looks open. This is external rotation. The normal has this normal contour and fossa. And this is a very nice paper, and I would advise everyone, because this is a very easy technique. It's nice to see it intraoperative. You can use your fluoroscopy, and you don't need so many sophisticated instrumentation. And okay, so now we know the fibula, rotation and length. What about the syndesmosis? How can I assess the syndesmotic reduction and fixation intraop? And this is always a question for us foot and ankle guys. How much is enough? How much should I tighten that screw? How much should I tighten that tightrope? Panel? Dr. Ahmed, Mukhtar, Osama? Is there a way that we know of to know that the syndesmosis is reduced?
I depend on the anatomical reduction, or I try to see the syndesmosis exposed to exploration of the syndesmosis. And then I like to, because I consider this like intra-articular injury. So
Yes.
I try to check by myself that the fibula is lying in the fissura of the
Okay. Okay. I, of course, use the arthroscopy, but that is not in all cases. Don't get me wrong. I will show you now a radiology. Mukhtar, you were going to say something?
Yes, in some cases, the syndesmosis is completely dislocated.
Yes.
You have to reduce it. Then you have to see the incisura. You have to see incisura, because I saw many cases that the fibula was fixed either in front of the incisura
Exactly.
or behind the incisura by two screws.
Exactly.
Because the surgeon fixed them blind. So you have to see if the fibula is the whole posterior, then you have to see the incisura.
This is a very
But
good point.
in a simple case,
Yes.
when we call it latent instability. The syndesmosis is okay, but when you do the hook test, it moves, but it's in place. But
Yes.
latently unstable.
But how
In
can
those
we
cases, you don't
check
have
it?
to visualize the incisura,
Yes.
and you can just put the screw.
Okay.
If you feel that you are in doubt, I always expose and make sure that the fibula is in the incisura.
And this is what we used. If you look, if you take a line across this is a radiological also with the fluoroscopy. If you take a line along the posterior in a dead, this is the most important part, it has to be a dead lateral. So the two domes of the talus are superimposed as one line. This talar dome, it has to be exactly congruent with this. Now, this is a lateral view, and if you ask anyone of my colleagues who works with me as assistants, they will tell you I always drape and even the other limb. I use the other limb. Anyway, this is the posterior part of the talus, of the fibula, where it crosses the talar dome. And you can see it always has to be after, posterior to the tibial plafond. Not even this. There is a line which has been described ever since 2013. This takes the epiphyseal plate at the junction exactly, going backwards to the anterior dome of the anterior cortex of the fibula and crossing to the posterior part of the tibial cortex. If you take these two bisectors, A over B, it should always be almost equal, 0.9 to be exactly. So I'll give you an example. This is one example, exactly like Mukhtar said. It looks perfect. The patient is being told by numerous surgeons, you're fine. But look at the posterior, it's outside of the tibial plafond. Look at the lines, and look at this. So this is anteriorly displaced fibula. And if you do the CT, there, you can see it. It even has, it is off the syndesmosis totally. So I would also encourage most of our juniors to start using these parameters. They are very good intraoperatively, and this has always been our problem. So it's the antero-posterior tibio-fibular ratio. And at that time, I used, this was 2016, and to be very honest, I won't say I knew it. I didn't know it at the time, but I took a comparative lateral X-ray of the other side. So I have now done the anatomical fixation. I know I have done my, is this enough? Now should I close the case and finish? Panel? Yes, I have to test the medial ligament. And actually, that is what I did. Now, we can debate in this particular case, should I fix this now or shouldn't I? I have fixed the syndesmosis. Why do I need to fix the deltoid? And this is still debatable. So anyway, I opened up, and as Dr. Mukhtar said, you will find it completely avulsed off, even by just, I didn't do except the skin. And the subcutaneous, I took a clamp and I pulled it, and you can actually see the talus right in front of you. I used 2 anchors, and then this is the post-op X-ray. And this was the other reason of which I did the arthroscopy. I wanted to check the medial side and know if I am going to fix it or not. And so I used the arthroscopy on the medial side, and you can see here the deltoid is completely off the medial malleus. So whatever I do, I know that this patient might end up with a pes planus afterwards. The deltoid is gone, and this is a main stabilizer of the ankle. So this is a 4B, and that's why I went with the fixation methods for the fibula, for the syndesmosis, and for the deltoid. So in the end, you can use whatever type of fixation for the syndesmosis. In an outcome of meta-analysis for the deltoid, it has been said that those who have the deltoid repaired, but mind you, this has a fallacy as a paper. It was not done on exclusively 4B cases. It was a comparison of cases with deltoid injury, just like that, general. They say that it has earlier benefit, but not long-term ratio. So this is the immediate 2 weeks post-operative. This is 6 weeks. As you notice, I do not remove the screw, but this is debatable later on. So this was the pre, and this is now, as we said, almost 3 years post-operative. We can talk about syndesmotic screw removal. We can talk about hardware removal later on. So in the end, as a take-home, there is very rarely a simple ankle fracture. You should have a high index of suspicion. Even on the phone, you can ask a simple question. You should not be afraid to use other diagnosis or investigation modalities when you want by suspicion. You should know how to reduce the most important part. Reduce your fibula. The fibula is the cornerstone, the rotation and the length. And we have to know how to assess that. Otherwise, we won't be doing the job properly, especially in comminuted, especially in malunited, like Dr. Mukhtar said. If you have both syndesmotic and deltoid ligament injuries, the ankle is still unstable. Even if you have fixed the fracture beautifully, your ankle is still unstable. And you have to fix probably the syndesmosis first, plus or minus the deltoid ligament later. Thank you, and I am really sorry if I overshot my time. I will try and stop sharing now. Thank you very much.